Hello, my name is Tiffany Ho, and I'm currently a faculty member in the Department of Psychology at the University of California, Los Angeles. I have been a contributing member to the ENIGMA Major Depressive Disorder Working Group for the past 7 years, and I'm honored today to share with you some of the science behind what we know about depression. I'll begin by telling you about how major depressive disorder, or MDD, is typically defined, its presentation, prevalence, and public health impact, some of the well-known risk factors for major depressive disorder, the heterogeneity of this condition, and what that may mean for treatment. An individual can meet criteria for the diagnosis of major depressive disorder if they endorse 5 or more of the following symptoms every day or nearly every day for at least 2 weeks. These symptoms include depressed mood, a markedly diminished interest or pleasure in activities, significant weight loss or appetite decrease, or weight gain or appetite increase, sleep problems, including insomnia or hypersomnia, psychomotor agitation or retardation, including a slowing of speech or movements, fatigue or loss of energy that can't be recovered by naps, feelings of worthlessness and excessive guilt, a diminished ability to think, concentrate, or to make decisions, and recurrent thoughts of death, suicidal ideation, and suicide attempts. Now, the first 2 symptoms on this list, depressed mood and a diminished interest or pleasure in activities, are also known as cardinal symptoms, meaning that an individual must endorse these symptoms in order to qualify for a diagnosis of major depressive disorder. It's important to note that in children and adolescents, depressed mood may often present as irritable mood, and that somatic symptoms, including headaches, stomach aches, are often more common in this age group. Mania or hypomania would be exclusionary for the diagnosis of major depressive disorder, even though experiencing these symptoms constitute a mood dysfunction or disorder consistent with bipolar disorder. Major depressive disorder is often recurrent in nature, with a single episode of depression lasting on average 4 to 5 months. Episodes of depression must be separated by at least 2 months to be considered separable, and up to 85% of individuals, even after being treated for their depression, will experience lifetime recurrence, meaning at least 2 episodes. Depression often co-occurs with anxiety, so over half of depressed individuals will also meet diagnostic criteria for a comorbid anxiety disorder. In terms of the prevalence of depression, it is relatively common. The lifetime prevalence is around 20%, meaning that 1 in 5 people will experience depression in their lifetime. The past year prevalence is closer to 10%. This chart here indicates the proportion of people who have said that they've experienced depression or anxiety symptoms. And you can see that the rates are relatively consistent across most global regions. It's not surprising then that the public health impact of major depressive disorder is large. It is currently the leading cause of disability worldwide. In North America alone, 33 million people are affected, and that is more than coronary heart disease, diabetes, or arthritis. In terms of the financial toll, costs are around 500 billion in the United States, tabulated according to direct treatment costs, absenteeism, lost productivity, and premature deaths. Given that depression is often comorbid with a whole host of other health conditions and is associated with an increased risk of suicide, it's not surprising then that a diagnosis of major depression is also accompanied by an increased mortality rate by a factor of 2.6. Now, this graph here simply depicts that the leading cause of disability globally is depression, and that it accounts for the largest share of the world's total burden of disease at 10.3%. This is all measured by according to years lost due to disability. In terms of who is at risk for depression, we can see that the age of first onset of symptoms tends to begin during adolescence and young adulthood. So this recent study found that a quarter of individuals indicated that their age of first symptoms began prior to age 17, but that the median age was closer to 26 years. The age of first diagnosis, of course, came later. And by then, you can imagine that these symptoms may have been impairing and distressing to a point where a medical professional had to be seen. In terms of age of first diagnosis, the median age tends to be 31 years. Sex differences are also prevalent in this disorder, with females being twice as likely to experience depression, and with this sex difference occurring starting during adolescence. By age 65, we tend to see this imbalance no longer being present. Here is simply data from the United States demonstrating that females, depicted here in orange, have higher rates of depression compared to males, depicted here in green, and that this sex difference is consistent and robust across ages, beginning at adolescence but ending by age 55 to 64. In terms of racial and ethnic differences, current cross-cultural data do not suggest racial and ethnic differences per se, and as we saw in that earlier chart, across nations, we are seeing consistent rates of depression being endorsed. However, when examining race and ethnicity as factors within a single country, we see that it appears that minoritized groups may be at higher risk for experiencing major depressive disorder, possibly due to sources of stress and adversity and disparities in health access. Who is at risk for a major depressive disorder? Well, across studies, we find that the most consistent factors or characteristics associated with depression include being female, having prior depression or other psychiatric conditions, not surprising given that this is a recurrent disorder, being divorced or separated, having social isolation or low social support, experiencing poor general health or major adverse life events, being institutionalized, abused, or tortured, having low socioeconomic status, or being unemployed. Of course, it's difficult to know whether or not some of these factors, such as unemployment, may be the cause or consequence of depression. This study or review by Kessler and Bromett provide a nice summary of many of the points I've discussed so far, including that depression is common. However, I did want to note that point 2, based on recent data, indicate that it may be that individuals in the poorest 20% of countries globally are experiencing higher rates of depression, contrary to what is stated in this review. But very quickly, this review indicates that depression is a commonly occurring disorder in all countries where epidemiological surveys have been carried out. The age of onset shows a consistent evidence for a wide age range of risk, but with a median age of onset that occurs during typically during early adulthood. The course of major depression tends to be chronic and recurrent, and women consistently across countries have a lifetime risk of major depression that's roughly twice that of men. Some social demographic correlates are less consistent, but overall, this is a disorder that's characterized by a range of indicators of impairment and secondary morbidity. As you can see, major depressive disorder is characterized by a range of symptoms, but what we haven't really discussed yet so far is how heterogeneous this disorder really is. Based on the symptom criteria that I've shown you earlier, There are over 1,500 symptom combinations that are consistent with this diagnostic framing. And I really love this quote by Dr. Eiko Fried, who states that depression is not a consistent syndrome with clearly demarcated boundaries, and depression symptoms are not interchangeable indicators of an underlying disorder. Current research practices lump individuals with very different problems into one category, which has contributed to the remarkably slow progress in the key research domains, such as the development of efficacious antidepressants or the identification of biomarkers for depression. Now, in terms of how depression is commonly treated, there are several antidepressants or pharmacotherapies, as well as psychosocial therapies that are used. Here is a list of such treatments, but selective serotonin reuptake inhibitors, or SSRIs, are the most commonly prescribed antidepressants on the market now. And psychotherapies, including cognitive behavioral therapy and interpersonal therapy, are also common. So how effective are these treatments? In clinical trials, 60 to 70% of depressed patients were shown to respond to these treatments. And a response here is defined as a symptom reduction that meets some criterion threshold, often 50% in these studies. And in a large review of 883 outpatients with mild to moderate depression without melancholia or psychotic features, the percentage of remission, meaning being symptom-free after an adequate trial of these various treatments, found that medications and psychotherapies that have an evidence-based really did not differ in their ability to effectively reduce depressive symptoms, and they outperformed control or placebo conditions. So that is quite encouraging. That said, up to 30% of patients with depression are not responding to at least 2 evidence-based treatments, and the recurrence rates are approximately 50% within 6 months of remission, even if the treatment was initially effective. What that suggests is that our current treatments may be limited in covering all patients who are experiencing these problems. And that is very likely due to the heterogeneous nature of depression, as we just discussed earlier. In terms of the implications of treatment, the future of depression research has really been focused on parsing this heterogeneity and taking a two-pronged approach to understanding what are the biological or neurobiological mechanisms underlying depression-related symptoms and behaviors, and hoping that we can then understand what are the subtypes on the basis of these brain circuit dysfunctions and potential underlying genomic factors. And with that, I would like to end with a list of keywords that I hope are helpful for you in understanding how some of these constructs and issues are defined in this presentation, as well as in the broader literature. And on behalf of myself and the other content creators, we thank you for your time.